Welcome, everybody. I'm Laura Gottlieb from the Social Interventions Research and Evaluation Network. We are so glad to be able to welcome you all to this webinar where we're going to have a chance to mull over the findings from the second report published from the Accountable Health Communities Demonstration Evaluation. AHC, Accountable Health Communities, is a large federal demonstration model that launched in 2017, focused squarely on social risk screening and social services navigation, and it was sponsored by the Centers for Medicare and Medicaid's Innovation Center. We've been eagerly awaiting these findings, and it's so fun to have an opportunity to talk about them today. For those of you whose interest may be piqued by today's conversation, the evaluation team's second report can be found using the link on this slide. The report has a lot of really interesting findings, and I say that as somebody who's read through it very, very carefully. In some ways, the data appear to tell us a really simple and very encouraging story. Healthcare-based programs designed to identify and help reduce socioeconomic barriers that can indeed affect healthcare outcomes. But the report's outcomes are also surprising and nuanced. I think they challenge our prevailing logic model that improved healthcare outcomes occurred because of receipt of social services. So to unpack these interesting findings, we invited a group of people who are deeply in the know. And I'm really happy to have a chance to introduce them today. Dr. Shannon O'Connor is the evaluation lead for the Accountable Health Communities Model Evaluation at the CMS Innovation Center. She is joined by Gigi, who is the former model lead for the Accountable Health Communities model. She's also at the CMS Innovation Center. And then we have two people who I now am glad to refer to as my friends because I've been working with them so closely for so many years. Dr. Lucia Rojas Smith is the RTI-based project director for the Accountable Health Communities Model Evaluation, and Dr. Will Parish is the RTI-based associate project director for the Accountable Health Communities Model Evaluation. So my heartfelt thanks to all four of you for making time for today's discussion and for all the time and effort you've all put in over the years on this major federal initiative. Just a little bit of housekeeping to our participants for today's webinar. Please use the Q&A feature to ask your questions. We will try to get to as many of them as possible. And just, I should say that because Shannon and Gigi are both with the CMS Innovation Center, there may be some questions that they're not able to answer just due to government rules about what they can share and what they can't share, but we appreciate all the candor that they're able to provide. And then last but not least, the webinar is being recorded and the presentation and the slides will be sent to everybody who registered for the webinar. As soon as it's available, feel free to share it with your friends and family members if your family members are interested in this topic. And then finally, please use this QR code. This is the SIREN QR code to just sign up for our newsletter, stay informed about other SIREN research to disseminate webinars. All right. And with that said, I am so glad to be able to stop the slideshow and just have a conversation with these magnificent people who are on the call today. So actually, give me 1 second while I switch over. My computer is acting a tiny bit slowly, but here we go. So, well, let's just start with this. So before we get into the actual evaluation findings, Gigi, I'm going to turn to you to ask if you can just provide a quick overview of the model so that everyone tuning in today is aware of what the model was and what the model was not.
Yeah, hi, Laura. Thank you. Happy to do that. And very happy and excited to be here with your audience to share all of this information. So first of all, the model screened all Medicare and Medicaid beneficiaries that consented for health-related social needs, and when identified, provided various forms of assistance to help them address those needs. The eligibility criteria for enrollment in our model was 2 or more emergency department visits in the previous 12 months and identification of at least one health-related social need related to either food insecurity, housing instability, transportation problems, utility difficulties, or interpersonal violence. The model tested the effect of types of interventions to address health-related social needs on healthcare expenditures and utilization. So the first intervention was known as the assistance track, and it randomly assigned beneficiaries to receive navigation to a control group or to receive the navigation itself. And when they received information, the control group would receive information also about resources available in their community. Beneficiaries who received the navigation intervention were assigned to a navigator who helped them to connect with community resources. So that was the first intervention. We had a second intervention in the model, which was known as the alignment track. And this involved a number of stakeholder engagement activities that included an advisory board and quality improvement to increase or improve community service capacity. This track was not randomized, unlike the first one. And all beneficiaries in this track received navigation assistance. The model was tested across the country with 28 bridge organizations, which is what we call the award recipients. And it came to an end in April of 2023, as I believe Laura had mentioned earlier. And the data for the evaluation came from surveys of and interviews with staff who worked at these bridge organizations, also from community-based organizations that the participating bridge organizations partnered with, and the beneficiaries who were screened for the health-related social needs. It also included administrative data collected from the bridge organizations and Medicare claims data. Hopefully that gives everybody an idea of the model itself.
Thank you so much, Gigi. It's super clear, very helpful, and I think ground, it's level setting.
Yeah.
All right, so let's jump into the actual results. And I'm going to turn first to Will and Lucia, because I know you have such a kind of very involved, detailed, complex understanding of what the report contains. And I guess the question that I would ask is what you think are the biggest take-home findings in this second evaluation report. Like if you were going to want people from this webinar with a couple of big ideas, a couple of big findings, what would they be?
For me, I think the biggest takeaway was that there was an impact on healthcare outcomes. Particularly, we saw that the model was associated with reductions in ED visits. And then a bunch of other hospital-based outcomes and total expenditures were also trending downwards, which was very promising finding from my perspective. One of the things that we've really struggled with in this evaluation is that we didn't really have as much power to detect effects as we thought we would or hoped we would have. So the fact that we're seeing statistically significant impacts on ED visits, even though that's just one of the outcomes that we looked at, I think is really promising, and it shows us that this model has had a really important impact.
Lucia, what about you?
You're on mute, Lucia.
All righty. All right. So for me, the biggest takeaway was trying to figure out what the relationship was between navigation and those lower ED visits that we were seeing. So we have some qualitative evidence that suggests that navigators were helping beneficiaries obtain medications, keep their appointments, or just connect and coordinate with case managers and other care coordinators. So this was for them going above and beyond just connecting beneficiaries with community services. And then we also learned, really interestingly, that those who received navigation were actually no more likely to resolve their needs than those who didn't get the navigation, those who just got the referral only or just the information. And among those who did resolve their needs, they found other ways to address those needs outside of AHC, which would include, depending on friends and family and even other caseworkers. So for me, one of the key takeaways was that you have to kind of consider all of these additional sources of support and the beneficiary's knowledge of these resources when you're trying to provide assistance. And then another really interesting thing that came out of this report, because it came out right after, this was the first report that came out after COVID-19, we learned that the pandemic really disrupted a lot of screening and navigation, of course, but that the bridge organizations did a really great job of implementing adaptations to overcome those disruptions. And that was in part due, or largely in part due, because of CMMI, the Innovation Center actually allowed them to put in place some public health flexibilities.
Yeah, that was super helpful, Lucia and Will. I'm noticing that in the chat, there's a question about not only what you and Lucia and Will think about the big findings, but also what our CMS colleagues, what Shannon and Gigi think of as the big results in the second evaluation report. And so I want to make sure to give you a chance to also answer that question. Gigi or Shannon?
I can jump in. So for me, I actually have to agree that one of the really big results was that despite whether or not those health-related social needs were being met through navigation directly, it had a huge impact, evidently. And so that is very exciting, unexpected, and to me, that was just a really interesting, unexpected outcome of this.
I have to agree with Gigi. That would be my biggest excitement about this report too. Particularly that although we don't know exactly how, we think it has something to do with trust and trust building rapport with these navigators, and how they're actually conveying how they're actually presenting the needs as they are. I'm sorry, I'm trying to think of how to say this. The best thing that we can say is that they're building this relationship with these beneficiaries and creating this rapport and establishing, hopefully for them, a better mechanism through which to get through to the health systems. So that was probably my biggest, the most exciting finding for me.
Okay, thank you so much. I actually am going to go dive a tiny bit more, Will, into your knowledge of the results, because I recognize that initiatives like the Accountable Health Communities that are designed to reduce socioeconomic barriers are increasingly a cornerstone of more comprehensive strategies to achieve health equity. And you and I have spoken about this in the past, and I'm wondering if you can share a little bit about what you learned in this stage of the evaluation about differences in the effectiveness of the intervention for different subpopulations too. You know, whether it's because of change in social risk factors or because of all the things that Gigi and Shannon were just talking about, change in trust, et cetera. What do we know about differences for different subpopulations?
Yes, we did look at some different subpopulations, and a lot of what we were looking at here was to understand whether there were important health equity impacts associated with this model. And we did find there were two subpopulations where there were larger or more pronounced impacts of the model. And those two subpopulations were beneficiaries who were non-white and or Hispanic. And the other one was beneficiaries who had more than one of the health-related social needs, so had food and housing, for example. And so we really think those are important findings from an equity perspective, because we know that historically these populations have faced a lot of barriers to accessing healthcare. And so if we're seeing these kinds of impacts of the model, it really suggests that the model has had a meaningful impact on reducing those kinds of historical disparities. I will emphasize their preliminary subpopulation analyses. We will have some more that we'll be looking at in the third evaluation report, and we'll have more data as we go forward. So it'll be important to see, do these findings continue to hold up as we continue to collect data on these beneficiaries.
Yeah, thanks, Will. Well, let me just ask, I feel like you've touched on this a little in describing what you think the biggest findings were, but I guess I would shift a tiny bit to ask, what do you think was the most surprising or unexpected finding in the evaluation report, and why? So Lucia, let me turn to you for that. I feel like there's some clues in the Q&A that we're seeing too, but I'm wondering if your surprises are the same as other people's surprises.
Yeah, so we have the hypothesis was that if you help people resolve their needs, that will then lead to the impacts on utilization. And what was surprising is that navigation didn't result in greater resolution of needs. But you still got the decreases in the reductions in emergency room department visits anyway. So much for that, so much for that piece of logic or hypothesis. So for me, it's really a glass half full story, because we know it's really difficult to address really system-wide gaps in community services. That was largely why navigators were unable to help beneficiaries resolve their needs. A lot, of course, issues with they weren't eligible, the waiting lists were too long, the services just weren't there, they weren't adequate or appropriate. Things that I think we're all probably aware of. But what I find encouraging about these results is that it shows that we can still have an impact while we're still working to close those gaps at the community level.
Will, what about you? What surprised you or was unexpected to you?
That definitely was surprising as well, but I did think of another thing that I found surprising in the evaluation, so this might take us a little bit of a different direction, but we know that one of the eligibility criteria for the model is they had to have 2 or more ED visits in the past 12 months. So we know that the model was intending to identify beneficiaries that had higher healthcare needs. And so it's not surprising that we found that beneficiaries did have higher healthcare needs if they were eligible for this model. But what was surprising was that they really looked like they were been struggling with their health and healthcare needs for a pretty long time. So when we looked at 3 years of baseline data on these beneficiaries, it wasn't just in that last year that we saw higher healthcare needs. It was actually all 3 years. And so it really suggests that, for a long time, these individuals have been facing health-related social needs that are making their utilizations higher, making their expenditures higher, and we're very ready to be intervened with. So I thought that was also surprising.
Can I push you on that for just a second, Will? Because I'm trying to understand that finding. Because if then we didn't actually, at least at the population level, decrease or what wasn't clear that change in social needs was the mediating pathway or mediator for a change in the healthcare outcome, why does that matter? Like the fact that they had been experiencing it in the intervention group, that they had been experiencing both higher social needs and higher healthcare utilization. Why is that a surprising finding?
I think it's just surprising how long they've been struggling with these healthcare needs. That we're not just, it's not an acute sort of short-term issue that we're seeing in this beneficiary population. This is something that they've been struggling with for at least up to 3 years. I mean, we only looked at 3 years of the baseline period, but could have been longer than that even. And it's just, to me, it's very eye-opening.
It just tells us a lot about the population that you're actually serving. I totally get that. That makes great sense. So let me actually turn to Gigi. So I just want to throw in a question that we're getting in the Q&A, and I think you would be best positioned to answer this question if you feel comfortable with it. We have a question about just telling us a little bit more about the role of the health navigator. So can you explain the role of the health navigator, duration of the relationship that the navigators had with patients, and any of the background that we know of about the navigators? And I know this differed across sites, but if you can give us a little bit more detail about that, I think that would help our audience.
Yeah, I'd be glad to. So as far as the health navigators, the relationship could last for up to 12 months from the moment in which navigation started. And the minimum touch base was supposed to be once a month. But it could last less than that if the need was resolved. And just to quickly come back and piggyback on what Lucia was saying earlier and the challenges there, one of the top needs identified was food. And yet this could be resolved pretty easily and pretty quickly in a lot of cases. And yet it could come up again. So that was another issue about unresolved needs, right? They could keep recurring. But to come back to the Navigator question, I just wanted to make sure that that was out there. To come back to the Navigator question, yeah, it really depended on the setting and the organization as to who they were, what their training was, what their background was. And so they ran the gamut from being a front desk, not a front desk person, excuse me, a care coordinator type of person almost, a social worker. Community health workers were increasingly used and very effectively. And that was something that was really exciting and has influenced and informed other social related or other activities of this kind with the social determinants of health within our agency. And as you can see, even with the new physician fee schedule that was just released, it's influenced and informed that as well, as far as potentially covering community health workers as navigators and assistants. And so the training in some cases was very involved. A number of organizations would supply them with trauma-informed training and give them scripts. And really give them support groups as well, meeting regularly with one another so that they could help one another with the difficulties and the flexibilities that COVID created in this area. So I hope, does that answer the question? Hopefully, okay.
Shannon, or Gigi, that's really helpful. There, one more question that's just very specific about the navigators, about whether they were only using in-person visits, and I know this changed over the course of the model, but or were they available by phone or computer, or did they have other touch points? And if you could...
no, that's a great and very important question, because that was an exciting outcome of this as well. So initially it was face-to-face, but again, with COVID, we introduced a number of flexibilities, and that allowed all kinds of contact points, from remote, whether it was through the computer, texting, phone, and something else that they did that was really interesting was two things. One, they would create what they were calling warm handoffs. They learned that when one person was screening and identified that there was a need, it was really helpful to, at that moment, try and hand over that patient to the navigator in whatever form. So the format didn't matter quite so much as having, those relationships as quickly as possible, back to what Shannon was saying, right? Creating that trust and supporting it to come over then to that navigator. And so that was one thing that came out, and also hybrid positions where they would have one person function as both the intake person, so to speak, the screener, and that navigator. And that also facilitated this. So once we had vaccines and things started to relax a bit, some returned to in-person, but not everyone did. So again, this was found to be effective regardless of that, which was really interesting, and I think really helpful and hopeful, particularly for rural areas where you may not always have the staffing that you need, but maybe you can still do this in a number of different creative ways.
So actually, that is somebody else asked a question about were any of the sites located in rural areas. So maybe you can just answer that too, and then we'll go back to some of the evaluation work.
Yeah. So the other thing that was really neat about this is it was conducted across all areas of the country. So we were in urban areas, some of the largest urban areas. We were in a lot of rural areas. We were in suburban areas as well, because the facilities that we used were varied as well. So it was occurring in emergency departments. It was occurring in inpatient maternity areas. It was occurring in various primary care and behavioral health settings. So again, another strength of the model, I think, that was really exciting to see as far as its future potential and how it can be translated into future activities, is it was successful in a number of settings and in a number of geographic locations.
Great. Thanks, Gigi.
Sure.
Will, there have been a couple questions that have come in specifically about that question related to the health equity findings and differences across different subpopulations. So just a clarifying question. were you suggesting in your response to that there were greater reductions in ED use or in readmissions for people of Latinx background or people non-white populations? Is that what the takeaway is?
Yes, there was greater reductions in ED visits, but there were also reductions that we didn't see in the overall population in total expenditures and inpatient admissions and unplanned readmissions. So not only was it more impactful on the one thing that was significant in the overall population, but there were more significant findings in those same groups that you're.
Just a reminder to participants to please enter your questions in the Q&A instead of in the webinar chat. I'm getting questions in both, and I'm just having a hard time tracking them across both. So please throw them into the Q&A. There is a very specific question about whether or not the team looked at outcomes by resource density. So for example, did you see the same outcomes for people living in areas that had low resource availability as for people who had high resource availability, which I think, really speaks to this question of, well, if, resolving social needs, not resolving social needs.
We did, but unfortunately, most of those results are in the third evaluation report, so I'm not privy to actually to describe those results. But yes, we did try to capture, we did look at measures of resource need in the community, and so stay tuned.
Stay tuned for sure. And well, I guess actually, this actually is a nice bridge to the question, just like, what outcomes will you be looking at in the third evaluation report? Actually, Will and Lucia, let's stick with you for this. Will?
Yeah, so there's a lot of new analysis that we'll be doing in the third evaluation report. One thing that we'll be looking at that we haven't in the past is really trying to understand how bridge organizations implemented the model and take that a little bit further and ask, questions like what factors, bridge organization, community level factors, such as what Lucia was talking about, contributed to implementation outcomes. So as an example, we're looking at some models that are trying to understand what factors were true at bridge organizations that had more success on connecting beneficiaries to community service providers to address HRSNs, and what factors were associated with some bridge organizations being more successful potentially in helping beneficiaries resolve HRSNs. So that's one of the new analyses that we're pursuing in the third evaluation report. Another thing that we're doing, since now we're kind of at the end of this performance period for these bridge organizations, is we're trying to understand whether and how bridge organizations are going to sustain the screening and navigation components of the model. And as part of that, we're trying to really put together a compendium of what are the lessons that we've learned about this AHD experience that could inform future efforts to identify and help beneficiaries with health-related social needs. And then lastly, we do have some additional subpopulation analyses that we're planning to do, which we haven't done in the past. And this sort of relates to this idea that navigators could be doing more, maybe doing more to help beneficiaries in navigating the healthcare system. And we thought they were just going to be helping beneficiaries with addressing these health-related social needs. And so in the next report, we're planning to look at beneficiaries with chronic or disabling conditions, so beneficiaries that have diabetes or beneficiaries that have substance use disorders, to try to understand if these navigation services maybe benefited those types of beneficiaries more than beneficiaries without chronic or disabling conditions. So
excited.
That's what I have.
That's great. There's a question in the chat that I actually think will be helpful for people who are trying to interpret this report, but then also is very relevant to the next report. Somebody is asking, how is resolution of need measured, which we've really struggled with, I know, over the course of the project. But can you weigh in on that and maybe describe some of the difficulties we've had?
I can take part of that question, and then I can also, invite Gigi if she wants to add in anything. So yeah, I mean, essentially it was the responsibility of the navigator to try to make contact with the beneficiary to decide whether, the need had been resolved. And usually you try to get some kind of confirmation from the so whatever resolved meant to the beneficiary, whether they no longer had the need resolved itself for some reason, but they had some category there that they would indicate that the need had been resolved. Now, there were obviously people they could not make contact with and who were essentially, quote, lost to follow-up. But that essentially, it was really whatever the beneficiary thought was resolved. So it could be they just, the need went away somehow, or they did make a connection with a service provider and they got the need resolved that way.
Right. And so related to that, actually, there's just an interesting question about the number of needs that beneficiaries had, and then findings based on different needs. And then somebody, actually, additional person asked about, well, were we able to look at specific interventions related to specific needs and the outcomes associated with specific interventions, like food related programs or very domain specific outcomes. Will and Lucia?
We describe some of the types of interventions, obviously 28 different ways, that people address these things, so times the 5 or 6 different core HR sends. So yeah, we describe it, but we certainly didn't have the sample size to do a full on evaluation of each intervention across each need. So, but yeah, we do in this report provide some descriptive information, the types of strategies, types of interventions they used, with each need. Yeah.
Also was a lot of beneficiaries that did have more than one need, and it was very complex, the overlap of different needs that beneficiaries had, which would make it very hard, at least in terms of claims outcomes, to try to say, here's the impact among people with that food needs, because people with food needs also, some of them have housing needs, some of them have transportation needs, or some of them have all 3 of those things. And so
Right.
Trying to disentangle that was not something we could do, and that's why we ended up looking at, let's look at people that have more than one need versus people that just have one, as one way to sort of, it's adjacent to that, I guess.
Yeah, I should add that, yes, there was, for every single need, there was documentation of whether that specific need was resolved. So if they had multiple needs, the system did track whether or not it was resolved.
We also did a beneficiary survey that we implemented too, so we could look across the systems track intervention and control group, for example, 6 months after they were screened, and ask them the same sorts of questions about their needs and see, do we still see food needs, do we still see housing needs, and that kind of stuff 6 months after they were screened. I think it was 6 months after they were screened. So that was another way we tried to measure resolution, so to speak.
There's some really interesting questions coming out in the chat that I think I'm trying to combine them because I know we won't have a chance to talk about every question. And so forgive me, audience, if I don't get to everything, but I'm going to ask a question just about the qualitative findings. And I was hoping that you all might reflect a little bit on, based on the questions that are coming out in the chat, this disconnect between our logic model being that the health outcome would be achieved via a change in social needs, and our findings that said, no, it really wasn't via a change in social needs, is confusing. I think a lot of people are grappling with that as they read the report, and clearly you all were surprised by the finding. And so a number of the questions in the chat have been well, let's talk more about that relationship with the navigator. How do we know that there was more trust, or that this was there's a positive experience going on there? And there's one really thoughtful question all of them are thoughtful questions, but one that's piquing my interest around a different interpretation, which is, well, we decreased costs, but we really didn't do anything for patients, anything meaningful for patients, or we're not achieving more something that is meaningful to patients. And I guess I'm just wondering what you found in the qualitative data that would make you think, if anything, that this other mechanism is the mechanism, that it was about trust, or it was about relationship building, or it was about some kind of more positive experience for the patients.
We kept seeing themes emerging from the beneficiary interviews and from the Navigator interviews that suggest that this is more than just connecting people to services. This was an attempt to really, figure out what that person needed and just trying to be helpful and supportive. So at this point, it's the evidence we have. I mean, we're trying to gather more for this third evaluation report. I would say though that I think that being able to measure trust and building that, I actually think that is something we do need to keep probing on and exploring in future evaluations, myself as an evaluator in this space. One thing we could not do with we did do a beneficiary survey. We could not ask them directly about their experience with the Navigator because A, it was 6 months after they were screened, and B, they may not remember. Like these people might have multiple caseworkers and folks like that, so you wouldn't know if they were really talking about this Navigator or another Navigator, or like it was just we really grappled with how to if we could capture that, because that would have been ideal. Like, what was your experience with your Navigator? Did you, but there was no real great way to do that in a robust way. So, I mean, it's a challenge for the field, right? Like, how do we measure that? So at the moment, that's what we're just seeing some really consistent evidence from the beneficiary side and the Navigator side that suggests to us, like, there is something positive going on there.
I'd like to jump in if I can also, because I can offer an anecdotal perspective. So as a project officer also on the model, we would meet on a regular basis, at least monthly, and had other points of contacts with what we call them bridge organizations, right? The award recipients. And we also required that they submit us on a periodic level stories from the Navigators regarding how it was going, what was speaking to them. And in all of these contacts in different ways, I was picking up, and I think the rest of my team as well, on how important the relationships were. And yes, the Navigators were going the extra mile. So I'll give you one quick story. As an example, there was a person who lived out, I believe it was Arizona in the desert, in a van, and one of those home van kind of things, camper vans, and he needed food. Well, they put him in touch with a food bank, and he didn't coordinate with the food bank. Now they had limited hours, limited days. Well, it turned out when the Navigator reached out again and was able to communicate with the person, they had some memory issues that were involved as well. So I don't know that it was dementia, but they had problems with memory. So the Navigator went the extra mile, got in touch with the food bank, and got in touch with the beneficiary, and developed a system so that the food bank or the Navigator, I can't remember which, probably the food bank, and the beneficiary would have a way to remind that beneficiary of when that food bank was going to be open, so that he could remember to go and get the food during that time. And then he got back with the Navigator, and the end result of this was deep appreciation, because it had been like a year since he'd had fresh produce or fruit or anything like this. He was living off of canned food and not that great quality. So now he could access that food bank. And this was huge for him. So there, and different kinds of stories like this. Actually, I think of the most compelling were, as Will was saying, where you had crossover in problems, where they may have had really mental health issues or behavioral issues that were a component of whatever else they were going through with their medical condition. And so that complicates all of this, right? And requires another level, I think, of both relationship and intervention that these navigators were able to provide. Again, just anecdotally, people with depression getting connected with the right resources and just staying with it until they did. And then the appreciation from the beneficiary when they did get those. Well, we weren't measuring depression, right? We weren't measuring that as a core screening necessarily. Well, we didn't really. And so that's not going to come up in this. And yet what a difference it was making to those beneficiaries that were getting this kind of assistance. So, maybe the other issue is also as far as how we measure what we include in those measurements. And maybe we need to be a little bit wider and really include the behavioral and mental health issues that we know are stressing our society too, right?
Thanks, Gigi. One point of clarification, Will, that insightful question in the chat or in the Q&A is when you were describing how the evaluation measured resolution of need, it sounded a little bit like it was resolved versus not resolved, but does that mean we're not seeing if something improved a little bit but didn't get resolved, we missed that in the outcomes?
No, there was actually another category, and I'm sorry, I don't have all the different categories, but they actually had several different categories of resolution. So it wasn't a binary resolved, not resolved. I mean, so there were certainly people who stuck with it through the end of it, and it was just unresolved. But there were, Gigi, this is where I probably would we don't have our sort of resolution guru from our team who really knows these data inside and out, but there were different gradations of resolution, I should say. I don't know if Gigi, you want to add anything to that?
Yeah, so my guru on that also isn't on this call, but what I can add is, for example, even with resolve, there was fully resolved, there was resolved to the point where the communication was made between the beneficiary and the social support. And maybe we don't know where it went beyond that, but that they connected. And that was a form of resolve that was also measured. So Lucia's right. There were different categories and sort of a spectrum of resolve. Now, a little bit better. I don't think we were able to measure that specifically, but it was not binary. That is correct.
Right. Thank you all so much for weighing in on that. I'm going to I will keep reviewing the questions in the Q&A. Thank you all for all these terrific questions. I do want to just make sure that we talk a little bit about two additional topics. And one of those is, I know there's a limit on what you can share publicly. So this is really for Shannon and Gigi, but can you just tell the audience a little bit about how CMS is planning to apply these findings to current and future innovation center models or to other CMS programs?
Sure, thanks, Laura. So first, we now know that health-related social needs screening and referral is scalable and important. So we're seeing that as an expectation for participants in most new innovation center models. We secondly also know that navigation can be an important support. So we're being thoughtful about how it should be incorporated in these new models. For example, in the new enhancing oncology model, patients receive navigation assistance for both their cancer treatment and their non-medical needs. We're also incorporating from AHC how to incentivize better care for patients with social needs. So for example, in models like ACO REACH, the Realizing Equity, Access, and Community Health model, and the newly announced Making Care Primary model, we're adjusting payments to account for social risk. And in the value-based insurance design model, we're now allowing participants to provide certain supplemental benefits like healthy food cards and transportation assistance to patients with greatest needs. We're committed to transparently sharing our learnings and data from our models. So I would encourage all of you to explore the AHC website, which includes a ton of great case studies, including more information about alignment activities, as well as guidance on using the AHC screening tool. We also have 3 more evaluation reports coming out in 2024, 2025, and 2026, which we'll be posting to the AHC website. And we do plan to publicly release the AHC data for use by the research community. And that should happen sometime next year, although I can't pinpoint exactly when.
Amazing. Thanks, Shannon. Super helpful. Well, so let me actually follow this up, and this is for all of you. There's a great question in the chat that I think actually is a good follow-on to the points that you were just making about, well, CMS wants to now have everybody implementing some versions of these programs and all these different models. But there were some big implementation barriers across the different sites, not only related to COVID-19, but COVID-19 and the pandemic certainly, posed some of them. But I'm just wondering if you could maybe speak to some of those big challenges and what you think will be, I'm imagining those challenges are not going to disappear for people who want to pick up elements of this model and implement things in their own setting. So can we talk about what we learned during the evaluation about those implementation barriers to screening and navigation?
I guess I'll start. I mean, I guess the number one barrier, and I'm not telling anybody what they don't already know, which is that we have just a lack of community services in many of these places, or even if you have the services, they may not really be theoretically available to people because they're not eligible. They don't have the transportation to them, the hours of, just all kinds of other issues that can keep a person from really connecting to services. So those are those bigger sort of community-wide gaps that I was alluding to earlier. And I would say that's really the biggest implementation challenge. I mean, I guess one of the things that this is really a surprise finding from the first evaluation report, going all the way back, was that we kind of went into this evaluation thinking that, and Laura, you'll remember this, that we thought that people would not accept the intervention. We were working from the literature saying, uptake on these kinds of interventions are in like the 30% range, and we were just kind of blown out of the water when we're like, wow, it's like over 70%. People are actually accepting the navigation. We thought we'd get a lot of no thank yous. And so that was a kind of a really nice surprise from the first evaluation report. So yeah, I think what I've learned to date is that people are accepting of these interventions. They do want the assistance. And, the navigation can be effective, even when, the navigator is up against, kind of things that they're completely out of their control. They can't create more food pantries. They can't create more housing, that kind of thing, but they can still have a really positive role in these and beneficiaries' lives.
Other folks who want to comment on implementation challenges? Gigi, I see your.
Yes, I'm jumping in. Yes, and agree 100% with everything Lucia said, but I'll share that, on a cautionary note, some of the challenges that we at the model level experienced was simply IT. Getting the IT systems in place. And of course, remember, this was back 2017, so even more challenging then. Now this is taking on a life of its own, more organizations and a lot of private IT companies are jumping into this. You've got health information exchanges that are coming into this area. So it's a different world now, but still, it still is one of the challenges. Getting the IT in place, making sure that you're collecting the data that you really need to be collecting so that you can evaluate it yourself internally later, because that was a challenge for some of our organizations. They wanted to show, they believed in this, they believed it was working, they wanted to have the data to show it to whomever they needed to show it. And they couldn't always get that themselves in a way that was going to facilitate what they wanted to do with it. Others who thought about it and added certain data elements on the forefront, thinking of the end in sight, right? They did a better job. So I would encourage people to be aware that that is a huge challenge, the data sharing piece, in addition to just the collection of the data and getting it in the system efficiently, right? Because a lot of these people don't have extra time. A lot of this is starting to get reimbursed, but not quite yet to the degree that some of these organizations would like to see. And so you've got to figure out how to do this efficiently. And you've got to figure out how to translate the data to the clinicians so that they can use it effectively, because that's something that we learned also within the model. clinicians might say, well, yeah, that's great, but what do I do if I find my patient needs food? And, what do I do with that? I don't know how to get them to where they need to go. So again, connecting all of those parts of the system so that it's a team and the clinician knows they're being supported, and there is either a food prescription, as some organizations ended up putting into place, or a pediatrician who knows that the baby's family is homeless. And so how are they going to train that baby to sleep? Okay, got to think about that differently now. So it can be very useful, but helping clinicians to see that and helping them make those transitions with data across the system, those were challenges. And there was a cost, right? There was a resource cost to that.
Gigi, I really appreciate that point. As somebody who has championed the potential utility of the social risk data to clinical teams, not just for connecting people with social services. But I guess I'm confused because I think you said we learned that as part of the model, and I'm not aware of that being included in the evaluation report, or that those data were collected from clinical teams. Can you clarify?
Yeah, so that is a little more of the anecdotal side that we internally came to find out, but we also did end up looking at it not from this third-party evaluation, which RTI is what, they provide an unbiased third-party evaluation of the model, but from our internal evaluation. And you will find some of this information and written up on our website, where we've looked at it internally from our own internal data, and as a model team with support internally to look at the data. We have produced some of our own information along these lines, and we have some tips on ways that you can help think about this to get that data sharing across all of those different specialties. And specialties, I don't just mean medical specialties. I'm talking about specialties such as a care coordinator, the front desk, to the clinician, across that spectrum of our healthcare system, which is so important, of course. And then looping it back, right? Because then there's a whole closed loop thing where you get it through the clinicians, you get it to the social support, and does it come back to the clinician that they did receive the food, that they did get help with what they needed? And for that matter, and I'll go one more now, can you tell I like this? I'm very, very passionate about all of this. A lot of the organizations in the social sector, they want data too, and they weren't getting it from our model. They were asking for it. They wanted that closed loop to know what impact did our services have for the beneficiary? Did it make a difference? And that can be used to then support getting extra funding, right, from funding sources. So data is critical, and it's just very hard sometimes to get what you need, and can be a big challenge and a big cost.
So one more implementation question that I feel like has come up in some of the questions that the audience are asking. Payment for navigators. So, I think what we're seeing here is that there was something special about the navigators. It may not have been that as robust a connection to social services, or as robust a decrease in social risk as folks anticipated or hypothesized when starting this model. But there was something important that the navigators, it seems to be that there's a signal saying that there's something important that the navigators were doing. So where is CMS on paying for navigators? What's Shannon, you sort of touched on this a little bit, but is that going to happen?
That's a good question, Laura. I can't predict the future, so I can't say for sure whether that's going to happen. It's certainly something that we've looked into. I wish we could say that we could provide resources for navigators, as well as for community resources. I think Gigi might have a little bit more information about this, so I'm going to ask her to take that question.
Sure. And yes and no. And so as Shannon said, we can't predict the future. Nor can we comment on policy that hasn't been publicized yet. Of course, this is something we all recognize as a need. And I think to that point, and this is on the yes part of it, the physician fee schedule for 2024 does give a nod to that. So if people will take a look at that, there is a section that is addressing the social determinants of health, and I believe it's more along integrated healthcare networks or something like that. And it does specifically mention community health workers who often were used in that navigator capacity. So at this point, we have to see where all this goes. I think that's the best thing that I can say. Certainly, we are excited and we support everything we can with AHC that's been found to inform future rulemaking and direction of both our agency at CMMI as well as CMS, but we're not the ones who make that determination as individuals here.
Of course, but thank you for sharing some of the things that are coming down the pike, and certainly I think everyone on the call is going to be watching with bated breath about CMS opportunities to support navigators and community health workers and et cetera. Okay, so I'm recognizing that we don't have much time left, and we're not going to be able to get to all of the questions that are in the chat, but I want to tell our audience that some of the questions are about publications that have been put out. We have a couple of them on the webinar announcement, but when we publish the recording of this conversation, we will again include the links to the 2 recent health affairs articles and to the overall report. And then Gigi, I'm hoping that we can also, at Gigi and Shannon, we can link to some of the CMS other reports that have been issued on this. So if you can share those with our audience through us, we're happy to do that, put them all in one place for people. And I just want to give my heartfelt thanks to the 4 of you for being willing to spend some time with this group today. We're so impressed that CMS committed to such a robust evaluation of the model. I know it wasn't, in retrospect, every evaluation can, we can add different things to it, but you can't do everything in every evaluation. And you did quite a lot in this one. And it's really, really impressive. And I feel like there's so much learning. And one more additional kudos, we just, as a research community, I feel like I can speak for a lot of people in the field saying we're so glad that the data will be made publicly available so that people can continue to learn from these data over time. That's a really big deal. It doesn't always happen, and it is a really, really big deal. So thank you for that. And I want to encourage our audience to keep analyzing these data over time, because there's just going to be so much to learn. So many, many thanks. Happy Monday to everybody, and stay tuned for a recording of the presentation. And please do be in touch if anybody has questions about the recording or access to it. Thanks, everybody. Have a great day.
Thanks, Laura.
Thank you all.